All right. So starting off, you've got a lot of people doing a lot of different things today in the general dentist market. A lot of people doing arches are starting to get into arches, and other entities are doing 50 arches a day. I know people that are in single location, 50 arches are being done a day, and you have a major separation in between the capital or the equipment each of those sites might have. Um, Generally speaking, you're going to have a lot of variance in equipment, right? Some offices are using $200,000 CBCTs. Some are using $50,000 that work just as well. Some are using whole teams of data collectors, physician-led. Others are sometimes utilizing assistants to go ahead and collect that data with maybe a little bit more variance in how good that data is going to be collected. You've got people that are running bite teams. You've got one person, one doctor just dedicated to deprogramming and getting an accurate bite, whichever way you want to do that. We can do a Coy's bite. We can Coy's the program. We can do a leaf gauge. We can do a manual by manual manipulation. You can do a mush bite. All of these work if you know how to use the specific method. Some are going to be a bit more accurate than others, right? We have different scanners. We have the Medit, we have the Shining, we have the CareStream, different generations. How many scanners have you used, John?
All of them. So before I was using a Medit scanner, Medit i500
Yep,
scanner. Well, when I bought my own scanner, I decided to just buy a scanner and go to the doctor's office and scan it. At the time, I had no idea like what to do. I wanted to work on more cases, right?
yep.
Uh, and it was
So,
interesting. But the Trios scanner like this, like other scanners were better at the time. So
yep,
I used the doctor's scanner a lot of times.
yeah. So there's going to be a lot of variability, and as long as you get the data you need, the scanners, the STL, the file data is going to be the final data, as long as you have the information you need. The question is, does the scanner make your experience capturing that a relaxing and predictable one, or hell?
Right.
Because I've had plenty of cases where I'm doing my scans and I'm just like, this is just not fun. Your major players in the market are the Medit. That's really not as much in many of the clinics going to be for full arch surgical scanning, but it's great for, say, doing a pre-surgical scan, no blood, it works fine. The Shining or the CareStream was, or which one? Blanking on the
Cheers.
name. Trio 6. Thank you.
Oh, Trios.
Trio,
Okay.
Trio 6 was the major one, I would say, in most of the clinics. Trios 5, Trios 4, even the Trios 3, going back a couple of years. That was probably the major one for most full arch clinics. And now with the Shining, with the bigger head, that's probably taking precedence among most doctors and most offices. Um, Pre-surgical setup, get your upper, get your lower. Everything's going to work for the pre-surgical setup. It works fine. Um, Common data gaps. The error with the scanners that you'll usually see is not in the pre-surgery. It's just you can scan that. It's usually when you're coming later down the line when you're doing your post-surgery scan, right? Can you get an accurate stitching of your tissue and your scan flags and everything you're doing without having a major misstitch, right? One of the biggest benefits you're going to want to look for is a big scanning head. Okay. The bigger the scanning head, the less effort that scanner is going to have to do to stitch photo to photo to photo to photo. It can get more overlapping data, and there's going to be less error accumulated across the arch. The reason why we're still using photogrammetry today is because we know even on an upper arch, which is the more favorable condition, we're going to have up to 200 to 500 microns of misstitching as a result, going from, say, site number 3, site number 2, molar, all the way across the arch, you're going to actually increase the error. Even just adding a palette, even if you're just doing a normal 2 scan, it'll actually increase that left side, the right side data. It'll misfit. The photogrammetry is going to give you sub 50, sub 30, depending on which brand you're using, accuracy for your implants. That's something we have to have. We can't have that variance we need to have it, right? Um, so when we're scanning, there's a couple different scans I'm going to want, right? I'm going to want my upper scan, my maxillary scan, my mandibular scan, and then my bite scan. John, here's a question for you. Is
Yes.
a closed bite scan or a open bite scan more accurate consistently?
Um, that's I feel like it's a trick question, but
No.
I always use close by it. I don't.
So, so having a closed bite, depending on which scanner you use, will
Uh-huh.
introduce more variability than anything else. Because when you have your STLs, your computer is going to try, depending on which software you're using, the Meta, the Trios, the Prime Scan, they're all going to handle STL occlusions where the STL is going into each other. They're going to handle those occlusions very differently, right? If you go back in time, the Prime Scan was actually one of the primary scanners for a lot of doctors that were doing full arch digital restorations
Oh,
for the reason that its software was handling STL collisions the best. It was
yeah.
doing it the most accurate. But
Yes.
here's the thing, if you open the bite and you have no collisions, you don't have to worry about the software handling that collision. So
Oh,
if you have an open bite, do an open bite, and you can take that for your liberty and you're already doing it, that will be the most accurate mounting of an upper and lower you can get.
I see. So I'm curious, how do you now how do you open the patient's bite? Do you just have them like just nothing, but not biting on anything?
No, no, no. You're not going to leave them holding in open air because you're not going to have any consistency. All right. What we want in every single time where we're opening a bite is we're going to want some sort of tripod. All right. If I have a four-legged table, right, no
Mhm.
matter what, it's probably going to wibble a little bit. It's going to be off a little bit. But if I have a tripod, there is no option but it for all those three legs to be sitting on solid ground. Right. And so in the mouth, we're always going to want to ensure that the two posterior legs are going to be your TMJ joints, right? And
Mhm.
then some sort of anterior stop. You can use whatever you want, right? You can use a leaf gauge. You can use a Koizda programmer. You can use a Lucia jig. You can use even a cotton roll. Whatever you want, you can do that. In certain cases, you will actually need to deprogram the bite and open them up so much in order to clear interferences between the teeth. But
Right.
then you need someone like John, and I'll tell him, hey, John, right? I opened this bite too much, but I needed to get the jaw deprogrammed. Please close this bite XYZ amount to get things back closed with the anterior or to reach the VDO that I want in the anterior. All
Hmm.
right.
Yeah.
Um, Data gaps. We've already talked about how errors in scans and stitching
Right.
can cause problems. We've
Hmm.
already talked about how there can be errors or an introduction of error through bite scans,
Right.
where different systems will do different quality data intersection algorithms. Different systems also allow you to turn off said data algorithms, where it will turn it off and it will just put the STL where the data is saying the STL is. The reason this is a problem, or the reason where this variance is coming into play, is because we're dealing with teeth. Your PDL is going to compress maybe 50, 100 microns. And your bite scans or your open bite scans, your mandibular maxillary scans, those teeth are static and no load. When you tell the person to close down, make sure you tell them to touch their teeth, don't bite. That will again reduce the amount of compression we have in that PDL, reducing the amount of change we're seeing in that vertical position of the tooth. Things will be more consistent.
Yeah, that makes sense. Touching versus actually
Touching, don't
touching.
bite, don't squeeze. Because if you think if you're squeezing, things are just going
Yeah,
around.
that makes sense. I've been always saying, bite, please bite.
Don't
Always
bad words, don't work. Close
biting.
gently, just touch, don't bite.
Yeah.
Right. So
Okay.
any other things on
Well, data gaps. Well, I feel like not only the bite, but
Data scanners? We're pretty
oh
good on
yeah,
that, I think, right?
I do have one
Oh, there
thing
you
I
are.
ask you. Sorry, I think we were
Yep.
disconnected for a few seconds. But
Yes.
yeah, Byte is my I think about Byte all the time, but something I noticed was especially coming from iCam background, right? iCam
Yep.
to Shining 3D. So
Yes.
in iCam, I always had to do the photogrammetry first, or and then do that like put the healing caps on and then do the scan and match the photogrammetry manually to the those healing caps, whatever.
Yeah.
What
So
does
so most of the systems out there today, right? They're going to have an option for you to export, right, different outputs, right? The photogrammetry, the iCam, the PEG, the micromapper. They will, what they're going to do is they're going to not give you a 3D scan. All they're doing is giving you a three-dimensional output. You
right,
have kind of like a coordinate system. You have an XY position of that screw and an angulation. That's all you're getting. So what John here is talking about is that prior to some of the more modern systems coming out, there was a manual alignment step that was required. The Shining system, being nicer and newer in some ways, we don't have to do that. That's actually built into the scanner software itself. It's going to see the scan bodies, it's going to calculate the XY coordinate data, the angulation data, and it's going to lay over that output onto the STL scan. So the merging is done manually. I would always still verify that that was done correctly by the system. It's just something I always double check just to make sure that there was no misalignment done. So,
right. Yeah, I personally I check do a QC, quick
yep,
QC after scanning. I see from the occlusion view if
yep,
all the photogrammetry is in the center of these healing caps, and
yep,
also I see from the front so that I can see how much the photogrammetry scan bodies are vertically compared to the healing caps. If they're similar height, then
yep.
I give it a thumbs up. Do you do something like that?
I do. That's automatically built into the system in the Shining that I use most regularly, and I
Right.
will just quickly look. For the benefit of everybody here, I know some people are doing full arch regularly, some people are not. Would it be possible for one of your team members to get a picture of that so they can have an idea of what that output looks like?
Um,
Maybe not for right this second, but for we can come back to it
yeah. Okay, yeah, we can do that.
if possible. And I'm going to, I don't know if I have the ability to send some pictures here, but hold on. I'm going to bring a couple photos for bike data later. Next thing, verification in 2026. John, when's the last time you did a verification jig on a digital workflow?
Oh, I actually had to do a verification check last year. I think it was last year. It's funny because I wanted to use photogrammetry, but the multi-unit abutment was not compatible, right?
Uh-huh.
And we already have the cylinders, right? So okay, why not? Yeah, let's just use the cylinder. I just connect
Yeah.
them, right? And yeah, that's what I did.
So you were knocked. You were effectively knocked out of photogrammetry, right? And for me, anytime I am knocked out of photogrammetry or a pure digital workflow, I'm going to return to a verification jig. That's what I'm going to do. I just know I don't have the accuracy and I need to go back to the analog workflows. There are a couple situations in today where even the most advanced clinicians are going to be going back to analog workflows. One thing that I saw recently, and I will give a nod to them for, Micromapper just came out with a scan body for the 3.5 micro MUAs, right? The reason I find that beneficial is because in certain cases, the 4.8 Noble standard MUA that everybody works with, or about the 4.8 SRAs, right? Those can be rather big and bulky if you're trying to put a abutment into a finer, smaller site. Not for FB3s, but for more FB1s where you don't want to choke out the connective tissue or the papilla. We need a more fine emergence profile. So, for example, Paulo Carvalho out of Portugal, he's a very known FB1 guy, right? He is typically doing a layout of implants that is typically a 3, a 5, a 7, 10, 12, and 14, right? What he'll typically do is he's going to do a tissue level at the molar sites. He's going to do a standard MUA at the first premolar, and he's going to do a micro MUA, right, a 3.5 at the 7 and 10. He's doing this because those are just kind of easy, nice, even distributions. And you're getting on average 1 to 2 steps a teeth. Your gap between each implant is relatively short. You're going to be able to go to zirconia only. You're not really going to be forced into a full titanium bar. Lowers cost, a bunch of different reasons. The other alternative I'm seeing people doing now, if they don't have that, is they're going to shift maybe to a second premolar,
Mm-hmm.
uh, into a canine, into a double for the 8 and 9, canine and second premolar. And the benefit of this is you're going to be putting your implants in sites that have a bigger horizontal space, right? Where you're not going to choke out the papilla or the soft tissue by using the 4.8. But the 3.5, that just opens things up. But that was the
Right.
first company that I know of that actually has a scan body that's compatible with that.
Wow.
You have a couple other companies that do have more variability. Give a nod to Pick, for they actually have a good number of flags that will
Mm-hmm.
be direct to the implant, so you can do a bit more bridge work. Um, Opens up doors, right?
Yes. Yeah, I
Um,
love this. Yeah, I love the companies keep coming up with the new parts,
yeah.
solving problems. Yeah.
So what I am waiting for myself though is a hybrid system
Uh-huh.
that you can mix and match, and then has a standard flag system that goes on top, and then I can mix and match as I want. That would be nice. No one has that quite yet.
Uh,
Long and short, as long as I'm doing photogrammetry, I am not doing any analog workflows. I'm not doing any verification jigs today.
right, right. Yeah.
So
Okay. Um, yeah, the next topic, if you're ready for the next one.
yeah.
Face scanning. How do you use face scanning data to help the lab determine the correct midline and lip support?
All right,
Uh,
so not every case is going to need face scan, but it's beneficial, right? And it also depends, who are you, right? Are you a larger system? Are you a larger lab where you are delegating all your data, right?
mhm,
And for the sake of consistency and lack of variability, you're going to want every single case to have every single same uh, quality checklist. You want to go through the same steps. In that case, I'm just going to facial scan everybody, right? It doesn't cost me anything. It's just a data collection step. I have to pay
yeah,
an assistant to go ahead and do it, right? If it's more like a bit more boutique, if it's just me, if I'm coming in as the guy doing the work, if I'm doing a lower arch, I'm not necessarily going to do a facial scan. I don't need it, right? I am being locked, both occlusively from function and aesthetics,
yeah,
to an existing upper arch. And there's really no, I'm bound in the face. I can't go any farther by the existing upper teeth. You won't need it, right? But if I was anybody building a system today, trying to do full arch consistently, a full arch facial scan would be a must in every single data collection. It's like taking a medical history. It's like taking a pre-op intraoral scan. Just do it, have the data. It's going to be consistent.
right.
There is some nice data out there that if you're
Mhm,
going to actually look at irregularities, if you're going to look at the asymmetries of people's faces, there's always going to be a tilt one way or the other. Look at the chin,
right,
look at the nose.
right, right.
And what you don't want to do is you don't want to go against the curvature. So if my chin is offset here to my left, right? Don't tilt your teeth, don't tilt your midline to the right. It's going to
Mhm,
increase the perception of it being off.
right, right.
Follow the harmonics of the face. There's data on that in the JAMA Journal of American Prosthetic Dentistry.
Okay. Well, talking about symmetry, I had this cases, right? And we're not talking about any bone structure. We're only talking about the lip. So
Yep.
let's say patient, patient's one side is going up more, so they're thinking, hey, this side, this canine shows up more,
Yep.
this canine is longer, and they're asking the doctor, why is this? Why did you make it longer this side, right?
Yep.
And we actually have to make it shorter. We had
So,
to,
so
yeah.
So here's a trick for you. If you're seeing somebody that has a hypermobile lip, right, which wasn't the exact case you were dealing with, right, you can actually do a Botox and you actually can see where your lip will drop to, right?
Oh,
So
okay.
let's say if you have the unfortunate experience, like a bunch of my friends, of an oral surgeon doing a case, didn't quite reduce the case quite enough. And when the
Uh,
patient smiles, you're starting to see that transition line, right?
uh, okay.
You can actually see, you
Hmm.
can actually estimate if you do this here in your own face, put your finger here next to the nose, smile, and that will be if you hit the levator anguli depressor, whatever this muscle is, I'm blanking on it. If you hit that guy with Botox,
Uh-huh.
that will be the height that the muscle gives you if
Oh,
you hit
okay.
it with Botox.
Interesting.
So if it's a low lip line or just a little bit too high, you can save a case with a little bit of Botox and not need to necessarily go back. It's gonna wear off, but maybe it saves you something in the short term. You can always do a lip repositioning, but that's getting into some more fun surgeries. But a lot of the times, if it's really, really extreme, you need to redo the surgery.
Oh, okay, I see. Transition line and the lip line. That's interesting.
Yeah.
Okay.
I would always try to ensure that the maxilla, it's the main thing that we're concerned with in terms of aesthetics, is
Mhm.
always set to the eyes, is always set to the horizontal plane. You know, if someone's like this, for some medical reason, we're not going to want to set the teeth like this. It's going to be set to the head, but try to make sure things are consistent. A lot of people doing high-end aesthetics are usually using natural head position, not necessarily in each pupillary data set. We know from a lot of facial plastics research that our pupillary lines, they're not level. And if you're trying to use those, it'll toss you off.
Yeah, I've been using a lot of eyes for the symmetry because exocad in
I
exocad it asks you
Yeah.
to click dots on the eye, and
Yep.
yeah,
So
okay.
you got to be careful with that because some people's left eye or right eye might be higher or lower on the right side or the left side. I know looking in the mirror myself, one of my eyes, I forget which one is higher. So the thing you can do for that is all Coy's research data on that. It's natural head position and using Coy's glasses, right?
Oh,
What you do with that is you put the glasses on the people. They have ball levers with little bubbles on them. You have them look to the floor. You have them look at themselves in a seated upright position into a mirror. Gets them into natural head position, and then you.
I think we're disconnected.
It's using the person's natural positioning to ensure that it's level with the.
Sorry, I think we got disconnected
Oh,
for
yeah, it disconnected. So 5 steps back. Um, look down to the ground, look into the mirror. We're going to capture that data. This is ignoring the variability of their eyes. This is ignoring the variability of their ears, of any asymmetry left to right side. And it's just using a natural head position to be very consistent.
I see.
Yeah.
Okay. Face scanning and the essentials. Now that face scanning is part of your workflow, what data do you still ask from the referring doctor? And what can a lab fill in digitally on your behalf?
So this again goes to whether you're working at a artisanal office or if you are working in a Ford or GM super plant. So for me, the way I've been working this last year, it's been me. It's artisanal. Everything is what I'm doing, right? I am doing the data collection. I'm doing the medical history. I'm doing the dental history, I'm doing the examinations, I'm looking at the CT, I'm looking at the scan. The year and a half prior to that, I was in the single largest implant clinic by volume in terms of single site in North America. So I wasn't doing any delay data, I was just doing the surgeries. All right.
Hmm.
So obviously we're going to have our upper pre-surgery data, our lower pre-surgery data, and we're going to have our bite scan. And that is all prior to the surgery day, right? And then in terms of face data, we're going to look for a couple different elements, right? We're going to have photos and we're going to have facial scans. We're going to want to set our upper teeth according to Emma, right? We're going to look for a resting lip dynamic. And what you're going to want to say is tell the patient, say, Emma, have the lips open just a little bit, and our standard deviation or our normal position for our canine is going to be level with the lip. Standard deviation is going to be up 2 millimeters, down 2 millimeters. We use the canine and not the centrals because the centrals are too variable. Males, guys, we're going to have a flatter upper lip. Females, especially young females, are going to have a higher labial bow. They're going to show more 8 and 9 than any guy will usually do so. So first thing I'm looking at for a lot of these people seeing me for full arch is go ahead and say, Emma, where's the canine? Where's that position? If they don't have anything, if they have a denture, right? Where is that canine and that denture? Where's the intaglio? I'm looking to get all that information so I know what I'm working with, right? So we've got the patient now digitized. We have photos, we have scans. We're going
Right.
to take a facial scan of Emma, right? That allows you to overlay multiple facial scans. We're going to have a retracted, right? With our retractors, we're going to have a Duchenne smile. Close your eyes. Ensure they close their eyes nice and tight in order to get higher dynamic movement of that upper lip. And those are your ones you really want. The optional one here on facial scanning is going to be a external facial scan block. Not sure if anybody's heard of it, but these exist to increase the accuracy of the stitching between the facial scanning and the intraoral scan data. All right. When you have a retracted smile, you're
Right.
generally going to have some pretty good, decent data in terms of mounting the facial scan left and right in terms of this way. Okay.
Right.
What you're going to lack in data, or you're going to be more subject to having the data be off, is going to be mounting the teeth and exocad in the
Right.
anterior posterior position. And you can tilt the teeth up a little bit, teeth a little bit, and it's going to change the entire case if you don't know what you're doing. The general variability is about 2 millimeters without the Coist scan block or any of the other ones. You can use any of them on the market. It just helps that data align better. So if I'm doing a double arch, I'm typically going to do that. If I'm going to do a single arch, I'm not worried because I'm still locked in against the other jaw.
I'm curious which block do you normally use for that?
I just use the Coist scan block because it's free. You can print your own, make your own. The instructions are online. It's open and available for anybody to use it. You
I
can
see.
go ahead and buy it for about 50 bucks or thereabouts. And there's also an 82 laser that will also mount on this that you can do more alignment with. It's a nice system.
I see. Is it like an impression, taking an impression almost, and
If
some?
you use the dentofacial analyzer, right, it uses the same trace. Right.
Okay.
So it's going to have a white tray. You're going to put it up against the upper teeth. This is also going to give you data to actually mount this according to the standard about 100 millimeters from your 8-9 facial surface to your TMJ rotation lens axis. So it also gives you that data.
So
All right.
interesting.
So that's all the data I am getting before patient scan day. And data of scan day is where you're going to have some variability. All right. John, you were using the arch tracers today. I also use arch tracers, but I'm also willing to use anything and everything out there. I've
Right.
used things as cheap as a 3D printed little round disc. I have used ARS Instarisa
Hmm.
screws. I have used other systems that have placements for MUAs to attach onto them. As long as we have something that is going to connect the pre-surgery and the post-surgery data, we're sufficient. We just need consistency.
Right.
But we
Right.
need enough data to ensure that the pre and post surgery data alignment is predictable and very accurate. So you had a problem earlier today. Why don't you mind sharing that, and we'll go over it and why different ones are an issue. If that's okay, if you feel sharing.
Oh yeah, yeah. I would love to. I think a lot of people are having this issue. Not yeah, not only me. Yeah. So we used it was a double arch, upper and lower, right? And we put fiduciary marker before the surgery for both upper and lower arch. For upper arch, we usually put a fiduciary marker in the middle of the palatal area, right in the middle. One is usually good, and upper arch is generally easier. Well, at least for me. But the lower arch can be difficult, especially because um, yeah, it's just the reach can be so narrow, especially the premolar area on both sides.
Yeah.
Um,
So for the people that don't do full arch consistently,
mhm,
right? When I'm doing an upper arch, we have a little bit more data that's very consistent. That doesn't get changed typically, and so it's easier to align an upper pre-surgery and an upper post-surgery.
right.
Me being a paranoid guy, I usually use two arch tracers,
Oh,
middle of the palate, straight up. The anchor is not too thick. I'm not usually having too many patient complaints, but it's
right.
very consistent and I'm very confident. If, God forbid, in my flapping of my palate, I dislodge one of them, I still have a second one and I'm not lost, right? So the upper arch generally provides the lab and the dentist more consistent data for a more consistent alignment of the pre and the post-surgery data sets. The bottom arch does not usually provide that, right? When you're usually working on the bottom arch, you're going to usually use a crestal incision and you're going to usually flap all the way down, or you should be flapping all the way down to the mental foramen on both sides and all the way back to the first molars. You want your implants going as far back as you want, and you want to see everything you can see. You also do not want to be stretching the tissue. If you're stretching tissue, you're increasing patient discomfort afterwards. Extend your excisions, get them back there, flap them nicely, and they won't hurt so much. But because we're doing this, we're going to be not having a lot of tissue that is very stable. This is also the hell for most scanners when you're trying to do a post-surgery scan. This is what everybody struggles with, right?
Mhm.
And so in this case, John was using a arch tracer, which is a single anchor device that's about 8 millimeters wide and it's not very tall, right? And he was placing it right here into the anterior, right about the 24, 25 region. And now continue your story.
Oh yeah. So yeah, extracted and fiduciary marker is here. So I scanned before the surgery, and I yeah, the bite was off. Let's say this is the upper and this is lower arch. If the bite is perfect, then it'll go like this. But the lower anterior was touching first when the patient was biting. So, based on the conversation with you earlier, I think it's yeah because of the fiduciary marker size is not big enough because we only had one here, and that size is not good enough to um, get the anterior posterior distortion. So it was rotated anteriorly, anterior going upward because the marker is not big enough. Because for the upper arch, right, we have that giant palatal area that we scan. So even though we're using a fiduciary marker, one or two, I think two is better. I should start doing that too. We let's say generally I use only one, but even if I use only one marker for matching, the palette,
Even if you have one, the palette doesn't
yeah,
usually change.
right,
You have areas where it's going to overlap well.
right. So,
Yep.
but the lower, yeah, we're gonna need a bigger
Yep.
fiduciary marker.
So you have a couple different markers on the on this out there on the market, right? One of the ones that from Arch Tracer is the buckle. I actually don't use that anymore. It's too narrow. It doesn't scan well.
Hmm.
But for up here in the front, I'm always going to want something tall and big. The more data that you have matching or being able to align a pre and post surgery data, the more accurate your alignment's going to be, right? So the arch tracer buckle, it's about 3 millimeters wide and it's about 6 to 8 millimeters tall. Doesn't scan well, it doesn't give me great data. The arch tracer palatal is about 8 millimeters wide and gives me enough space. Gives me a lot of data when scanning from the top. The Instaresa screw, the Segmark ones, those both have systems where they have a scan body that goes on top. That's going to give me more data. If you want to be technically the most accurate here, you're going to use a CBCT workflow. Um, how many people here have even heard of a CBCT workflow? Have you done a CBCT workflow? It's a very specialist thing, and most people do not work with it.
I've done like one case so far.
Yeah, exactly. One case. And you're one of the bigger labs attending all the meetings and doing this, right? So
Mhm.
the benefit of a CBCT workflow, right, is that our alignment data is the jaw. It is the skull, right?
Right. Uh,
It's you
uh,
you you have all the surface area you want. But here's the question: did you capture the pre-surgery bite setup in the CBCT? Because if you didn't, you have no bite, you have no information.
right.
Or if you're like me going office to office, is the CBCT consistent enough to give you the data you need? And
Right.
I have not seen that. So you
Um,
need like a $200,000 CBCT in order to run that workflow. And there's even $250,000 rolling horizontal
uh,
CBCTs that you can actually then take the CBCT of the patient while the patient is still sedated. You
yeah.
have to take the headrest out because it's metal, put a
Oh,
fiberglass headrest underneath the patient. They're sedated, they're asleep, take it, send the data off, and then you can do that as well. So, but this is getting into some exotic workflows.
right. Yeah,
Yeah.
I always want to do it. I wish there was like a handheld CBCT scanner. It would be super cool. Just
That'd
scan
be
it.
nice. That'd be nice. On the CBCT workflow, I also know an office that recently zapped one of their patients with 6 post-op CBCTs in about 5 minutes because they weren't getting a good one and the assistant didn't know that was bad. So
Uh,
that's another problem you can run into. You're not going to you're not going to expose the patient to a bunch of radiation if you're just scanning them a bunch of times.
yeah, that was.
We,
Yeah.
go ahead.
Oh, that was my conversation earlier today with another doctor. Yeah, when I was talking about the CVCT workflow, because like I was going crazy, like how is the bite off? Last few cases they were perfect. Why did this one go wrong? I mean, not completely
So,
wrong, but yeah.
so if you want, for more people who are doing it or not doing, you can put your anchors here as well.
Right.
But what you're going to do is you're going to improve your anterior posterior accuracy of your biont. But what
Yes.
you're going to trade off is you're going to trade off a little bit like this. You're going to lose a little bit of left and right accuracy because when you have the patient open, you're
Mm-hmm.
going to have an inward tension force on
Mm-hmm.
that mandible. All right. And you will see if you put your TADs in the retromolars and then the retromolar pads, you'll see, generally speaking, some degree of variation in that position left and right. It's not the most consistent, but it'll get you somewhere. And as long as it gets you close enough, you can work with it. Right.
How much is it going to be off if when the right and left side?
It depends on the patient, right? So I have had patients where we did photogrammetry, right, with the patient open as much as they can. When the patient's open as much as they can, we're going to have the most amount of torsion on the mandible. If you actually want to have if you have implants behind the mental foramen, right,
Mm-hmm.
you will have a better fit most of the time if you actually take the photogrammetry in as closed of jaw as you can, because it's closer to the passive closing position, right? So I've had people that have had the arches installed, zirconia is finals usually, the PMMA is flexible enough it doesn't cause an issue, that it hurt them when they closed. It
Mm-hmm.
was tension in the jaw
Oh,
when they closed. And then when
okay.
they opened their mouth, the pain went
Right.
away because it's fitting the implant position. There's less tension. So if
Um,
you're going to choose one of these positions and you have implants behind the mental foramen, You want to choose one of these positions to be the more neutral passive, take the data set with the bite as close as possible. They'll put tension on it when they open, but they don't live there.
Hmm. Oh yeah, that makes sense.
The other option is to do a segmentation, more implants and put a midline split in it and separate the bar. But
Oh,
that's not too common in the market, but it's an option.
I see. Do you have hard time scanning those retromolar pad finish
Depends on the scanner you're using.
Okay,
I have spent 45 minutes with some scanners trying
wow.
to scan the lower on a post-surgery scan. That I have then gone ahead and brought my own shining out and then been like, "Boop," and in about 2 minutes captured the entire thing. There is a significant difference in the different scanners on the market.
Okay,
So
that's
I, I,
weird.
I almost embedded that Medit scanner in the wall. It was very frustrating.
Oh, you were using Medit too before?
So the different offices I have, so if I need to, I have my shining unit.
Uh-huh.
But different offices I have either A, don't even have any scanner, which is annoying,
Right.
or B, use a Trios or C, use a Medit. The Medit has been the one that I've had the most consistent issues capturing the lower posterior mandible with.
Oh yeah,
Has that been your experience?
I mean, forget the lower. Even for upper, I was having issue with the edentulous upper. Yeah, so lower
Yeah.
is yeah.
Yeah, so it also generally has not that big of head on some of the older models. The i900 has a bigger scan head, does
Oh
pretty much better, right?
yeah, much better.
Yeah, and blood rejection algorithms and other stuff also plays a role.
Yeah.
So we've done the essentials. We know the data trying to look at getting. We've got our intraoral scans. We've got our bite scans. We've got our facial scans. We've got our photos. We've got some talk about photogrammetry. We'll go into that a bit more. Managing VDO, right? Um, this is going to be something that, as long as you are not really opening the
Mhm.
patient a ton up with, they
Right.
will tolerate it, right?
Mhm.
I am usually ballparking it with just a VDO gauge, and it's consistent enough. The problem I'm usually seeing with VDO is actually in under reduction cases where someone didn't reduce the mandible. It's typically this is the most problematic area, right? Where the the screw is coming out of the occlusal surface, and because of the height of that screw, we're being forced to open up that jaw. We have a 1-to-3 ratio. If we're opening up 1 millimeter in the back, we're opening up 3 millimeters in the front. If I have to open up 2 millimeters, case is
Mhm.
dead. You know, there are some exotic solutions, right? If you have a six implant lower, right?
Mhm.
You can, and if you have a good lab like John here, you can actually go ahead and engage the four anterior screws and close up the screw channel access for the two back ones.
Okay.
There's some ticks you can actually use, but that is a exocad at its limit, and it does not want to do that. But you won't have a screw to deal with, forcing you to be open farther. All right. Generally speaking, I'm just using a leaf gauge because it's the most consistent that I have, and it's cheap and works on everybody. It will tend to distalize the joint if I need to be careful. If I was working in a very, very high-end clinic and I had complete control, I would be using more of a Cois deprogrammer because I will get more consistency in the joint deprogramming. It's a flat occlusal plane and it's not pushing the teeth forward or back or left or right. If I'm typically using a leaf gauge, right, and I'm putting them against the teeth, it's going to be pushed up, right? And then if the teeth are here, there's a tendency to slightly distalize that lower jaw just a bit. And if that's 100 or 200 microns, that's enough to cause a little bit of variability that removes some predictability.
Right. Makes sense.
Yeah. Prototypes. What is the worst number of prototypes that you have dealt with, John? I know an office that I was doing work for, they have done up to 17 try-ins.
Are you serious? 17?
17. That's the highest number I've seen.
Oh man. I don't think I reached 17 yet.
It's a
Oh,
it's a lot. That's that. It should not be 17. At 17, we're losing money and it's a headache.
Yeah, I think most. What's your? I'm curious. What's your opinion on how many trying is the usual number you're seeing at like average?
If I'm over two, something's going wrong,
I agree.
right? If I'm over two, something's going wrong. Um, I've also been in an office where I was using an in-house lab that literally could not duplicate
Mm-hmm.
a STL, right?
Oh.
So this was a surgery that predated me, and
Mhm,
the surgery was acceptable. There was no surgery change that was needed,
mhm,
but his bite was off, and he was very sensitive to the bite matters, right? You've got different people that like their joints are not happy if they're out a little bit. So I couple times I on three separate occasions I deprogrammed this guy and I equilibrated him according to Coy's principles, according to anybody, Dawson, Pankey. If you know how to deprogram and if you know how to equilibrate, it's all consistent. I did
mhm.
it on three separate times. Each time took me each time took me an hour, right? To get the
Oh,
bite right, to get a stable occlusion, to have hold stem stock on both sides. I dialed the bite in, right? He's like, patient's happy. This feels good. He goes away. The lab couldn't duplicate the STL. And then what am I supposed to do? They couldn't do anything, right?
yeah,
So make sure you work with a lab that is at least competent, and then you won't be stuck with that.
yeah. We
So
we teach exocad too.
yeah. Because duplication is like ExoCAD 101, and if they can't do that, they don't have any business doing the work, right?
Yeah, yeah.
Um, so yeah, most of the time, digital try-ins, one, maybe two. If it's more than that, you might have a problem with the patient or you might have a problem with your lab. If
Yeah.
you have a good lab like Artisan, it's probably more a patient expectation issue. And then you're stuck dealing with patient expectations, and it should be something that you should always be looking at before you touch the patient at all. You're never going to get a 60-year-old to look like a 30-year-old.
Yeah, I think try and there are so many things that can go wrong. I mean, if it's someone's first time, working on a full large case, from the data acquisition to communicating with a lab, and also on the lab side, there are so many things that you have to think about too. Like one misclick on exocad, like one mismatch, like you have to match like five or four scan data, right, for per
Yep.
arch. If
Yep.
you miss one of them,
Yep.
then
If your alignment is off on one, there goes your case.
yeah,
It's double check, double check, double check. So,
so
what was the worst try-in that you have seen?
worst trying.
Yeah,
Um,
just
trying.
completely just data off, just having to grind it in.
Yeah, I guess occlusion by this the most common trying,
Yep.
especially let's say, yeah, I was going crazy at one point last year and 2 years ago because this one office, right? Everything was good until the trying. Actually, the trying were good, but
Hmm.
when we duplicate that like exact same data to make zirconia,
Yep.
okay, now the bite is off. I mean, not completely off, but like
Something was off.
yeah,
Yep.
some yeah, just a little bit big enough for them to see the difference.
Yeah. So as
Yeah.
long as you have the bite data, if you have theoretically, right? If you have good upper scans, good lower scans, um, and a good deprogrammed bite that is consistent, that's not going to change, then you should not see any change from your prototypes to your final. It shouldn't be, right? You might need to just go think, for about a minute with like a very fine red striper and then a polisher. But typically you don't need to be sitting there grinding this in for 5 minutes. If it should be just, a light adjustment at most. Um, the problem with the try-ins that I have seen the most consistently have been in denture cases
Hmm.
and have been in perio cases.
Okay.
Situations where the data that we are collecting initially is going to be compromised, right? So if I'm doing a denture bite, right,
Mhm.
I am typically going to go ahead, drill out the denture, right, put my tabs in, take my
Right.
scan, right, pushing up on the denture and taking the relationship of the tabs to the denture acrylic. around it and then extending that scan. But because the denture is not stable, I'm going to
Mhm.
have some variability in that fit, right? And that's going to introduce some error. The other situation I will see an error in is when I'm dealing with very, very mobile perio teeth. It's impossible at that point to get a very accurate bite. I'm
Right.
not going to chase a perfect bite on those cases. I'm not going to bother. You're going to waste more time
Oh,
trying to
okay.
get this perfect than accepting that it's going to be imperfect and just know that, hey, John, I've got a denture here, I've got a perio here. I'm going to scan, right, at delivery, and we're going to reline that bite with the first interim, with that first temporary, right then and there that same day. I know it's going to be bad. And because I have implants and because it's now stable, I can get a great bite off of that, and then it can be predictable.
Right.
You're not going to get it with an unstable denture. You're not going to get it with an unstable perio situation.
That makes sense.
Yeah. So that's digital try-ins for you. Troubleshooting. If you're doing all this predictable, if you're doing this day to day and you're doing your check marks, if you're doing your checklists, if you're getting all the data you need, you're not going to run into problems all that often, right? Um, I've probably had one bite off, maybe my anterior anchor moved, rotated, maybe something moved when I was elevating and working it. But generally speaking, it's pretty consistent data. Um, it's not usually an error that you usually see if you have the right workflows in place. And the times where error is going to be introduced, a la those perio cases, a la that denture case, you already know it's there and you're already planning to compensate for
I see. I'm curious about your setting when you're doing the bite scan, especially with Shining 3D.
it. Yeah.
Do you click that auto bite adjustment button, the blue icon
I
on the
usually run it, but a lot of times I'm also going ahead and opening the bite in a lot of my cases,
Mhm.
which again is going to be the most accurate bite we can get because we're not playing the game of where is the algorithm adjusting the STL for the interferences that they're playing with between the maxillary and the mandible.
Right.
The open bite is going to be consistent. You won't have to worry about it.
I see.
That
I see.
algorithm is playing when you're taking a closed bite, right? When you are dealing with PDL compression.
Yes. So don't bite, only
Don't
just
bite.
gentle
Yes.
touch. Okay.
And the most accurate bite you can get is going to be an open bite.
Right. Yeah. Yeah. I hear these keywords all the time, every day. Bite, please bite, or
Yeah.
open during the surgery. Open, and
Yeah.
then when you're yeah. Okay.
Yeah. Communication. The biggest thing is, I'm only half of the puzzle here. I'm on site, but I need John here to be able to back me up. And I want to be able to whoever I'm working with, I want their cell phone and I want to be able to call them immediately.
Um,
Um, I don't generally work with some off. So for this type of work, I don't work with offshore labs. I want a person I know personally who knows my preferences, and who I can physically talk to.
yes, I agree because there's so many things you have to communicate, and also it's better if you already have that understanding, so that you don't
Yeah,
have to go over that whole thing
yeah.
again. Yeah.
Well, that and a bunch of these larger labs, while some of them are decent, some of the bigger labs that are chasing the digital designs for lower fees, you don't know who you're getting. I'm seeing a bunch of designs with no curve of speed, no curve of Wilson. Um, they're not setting the teeth up right. And if they can't set the teeth up right, you're lost. You're stuck. There's nothing you can do.
Hmm. I
So,
agree.
yeah.